Okay, so good morning, everyone. It's a pleasure to be here today. In the next 20 minutes, I'm going to give you more an example of how we can use AI to treat patients in clinical routines. This is a work which has been started a few years ago and which is headed by Sarah Watson, who is a medical oncologist at Curie. So we are talking about a very specific type of cancer, which is a rare type of cancer that we call cancer of unknown primary. So to make it short and simple, basically that's patients who has large metastasis sites, meaning that actually we start treating the patients where they have metastasis, but we don't know where the cancer comes from, right? So you have here an example where you have, where is the, yeah. No, yes. So you have metastasis site here, but actually you have no idea about where the cancer comes from. In terms of treatment, that's a big issue because, well, you don't have the source of the tumor, so you try to treat almost all organs, making the assumption that by chance you will finally treat the primary tumors. So that's a rare disease with around 2 to 3% of all cancer type. But it's still a few thousand cases in France per year, so that's still a lot of patients. So, you know, in Europe, we have a couple of recommendations about how to treat such type of patients. This is the work of the ESMO for the European Society of Medical Oncology. And actually, there is a few things which are interesting to see here. That first, for this type of approach, now sequencing of genome and also gene expression sequencing is advised to treat the patients, and I will show you how we can use this information. The second thing that you can see here is that actually in this kind of decision tree about how to treat the patients, you have for the first time AI classification, which is advice to help the physician to take the decision. So there are in the literature a couple of, let's say, clinical trial which has been done to try to see how the molecular profiling of those tumors can be helpful for the patients. And to make it short, you see that each time you are trying to use either DNA sequencing or RNA sequencing and try to drive the therapeutical options, you can increase at least the survival of the patient to 3 or even 4-fold. So, so the question we try to face is this one. So we have data from metastasis cancer, and the question is, can we detect, can we predict where the cancer comes from? Can we find the primary origin of the tumor? So these rely on a very strong biological assumption, which is that actually we make the assumption that the metastasis will share at least part of the epigenetic or gene signature with the primary tumors, right? So meaning that if we take the metastasis sample and try to compare them with all data we have on primary tumors, we should be able to match the profile and to make a prediction. So this is something which is known now in the literature, but you also have kind of debate about how different are metastases compared to primary tumors, and that's something we can also discuss. So the question is how to predict the origin of the tumor, and you have many different ways to do that. In the last 10 years, you have many different AI tools which has been proposed for that. The difference is mainly the type of data you are using as input. You have classifiers that will use DNA, other that will use gene expression. You can also use images from pathology, clinical data. You have differences in the in the cohort, which has been used to train the models. The number of tissue they can also predict. Some classifiers are done just to predict around 10 tissues. Some others go until 50 or even 60 tissues. And the performance can vary also from a cancer to another and a tissue to another. So what we have done first is we try to build a large database to train the models. That's always the main issue that we have, and previous talk already discussed about that. So we use two public databases. The first one is GTEC, which is a large collection of normal tissue, which has been sequenced mainly in RNA-seq, so gene expression, but also at the DNA level. And we use another large database, which is called the TCGA for the Cancer Genome Atlas, which is an American database where actually you have thousands of samples of patients which has been sequenced at the molecular level. A few years ago, we made the first AI tool, machine learning tool to predict the tissue of origin. So how it works, so we are using gene expression data. The model has been trained on many data. And we are able to predict more than 40 different tumor types. So here you have example where you have a big map where each dot is a type of cancer. You have the annotation. And within this large map of all tumors, you have the red points, which are where we try to predict where we put the patients. So for instance, for this one, we predict that actually you have a contamination by liver sample, okay? This work has been done by Julien Vibert, who were a PhD student at Institut Curie, and is now used in clinical routine for all patients with cancer of unknown primary. Okay, so very briefly, because I don't think that's the main topic here, how it works, that's a kind of, that's a classifier which is based on both deep learning and machine learning methods. You have an autoencoder that will reduce the dimension of the data to work with latent spaces, and then we were training multiple machine learning algorithms. And so at the end, you train the data, you have the classifier, and it gives you the probability of the primary tumor. So the performance of the model on the test set was extremely good, with more than 95% accuracy, which is extremely really fine. But then when we try to apply it to real data, and especially to real cup data, we saw that the performance are decreasing. So the main issue that we have with the cup is that, by definition, we have no idea about where the primary cancer occurs. So that's not a real grand truth data set. So we don't know what is the truth, so it's difficult to measure any accuracy on that. But the only thing we can do is that actually we are trying to compare the prediction of the model with all known clinical information about the patients. For instance, if you have a smoker patient and that tool predict that this is a lung cancer, it makes sense, okay? So that's how we are comparing the prediction. In practice, we think that it's working in around 75% of the patients that we have to treat. So why not on more patients? First, because the classifier has been trained on few cancer types, but not on all cancer types, because we have a lot of rare cancer for which we don't have any data available in database. So if the classifier is not trained on those data, there is no way to find them, right? Then we can also have some technical issue, because that's based on sequencing assays. you have technical points where the quality of the material, the quality of the biopsy, that can also influence the results. And the last one is based on the assumption that actually we did, which is that the metastasis should look like the primary tumor, which is maybe not always the case. And in this case, we cannot find them. So how we are organized in France to treat this kind of patients, you have what we call a molecular tumor board. So let's say that this is a kind of group where you have experts in oncology that will discuss each patient. So it's organized in two steps. The first one, it's basically where you have any cancer center in France which can just propose a new patient. And so the oncologist would just discuss this case. If they validate the fact that this is a real cancer of unknown primary, or there is suspicion that this is a cancer of unknown primary, the patient enter in the France Médecine genomic plan. So you will sequence the DNA, the RNA, you will make many additional information, you will collect all the pathology information, all the clinical information, and this is done within a few weeks. And what you can see here is that for the first time, we are using the AI model, the prediction model, in the molecular tumor board to take decision at the end. Once we have all the data, there is a second molecular tumor board where everyone discusses the results and take a decision to treat the patients. So the MTB has been set up a few years ago, 2020, and what you have here is just the number of patients that could benefit from this kind of system. And you see that it increases every year and we are this year we got around 250 patients, which is already something very nice, and we are seeing the curve that continue to increase. So how it works? So this graph is a bit difficult to see, but I will try to explain it clearly. So here in the first column, you have the suspected tumor of origin. So when the doctors present the patients. In some cases, the cup here, the doctors have no idea about where the tumor came from. And in some other cases, they have some idea because of the clinical history of the patients or other data available. And the thing which is interesting here is that here you have the final diagnosis. So what is the final output of the molecular tumor board? And you see that for almost 2/3 of the patients for which at the beginning we have absolutely no idea about where the cancer comes from, at the end we are able to propose at least one origin of the tumor and then to orient the treatment to those organs. And so the evidence, so how we take this decision, each time that you have molecular here, it means that the decision was taken using the classifier as an output. So it's not the only information. Usually you have, for instance, decisions which are based on the classifier and the pathological data, on the classifier only, comparing all the available data. So it's kind of, you have multiple data in as output, but still we are able to improve the patient's care using the system. The only thing that we can do with such tool, I mean, it's to do much more research in biology. So here, this is a very small example of what we have done a few months ago, where we were interested in a very rare type of tumors, which is called metastasis renal cell carcinoma. You only have a few cases per year, so that's really rare. But actually, we have no idea about the biology of those tumors. So using this kind of predictive model, we can try to match the primary tumor and better understand what is the biology that you have behind this type of tumor. And even we were even able to make two groups of patients, one that will very well respond to treatments and the other one for which it's much more complicated. So doing this type of analysis, we can make group of patients and treat the treatment and choose the treatment. Okay, so now that we have this model, the question that we started is, can we improve the model? So far, we think that it works for 75% of the patients. Can we do better than that? So we first started by spending a lot of time cleaning the data. I think that's the main part of the job, is being able to have a very clear data set to train the model. Then we update a bit the classifier with additional model. And so just here you have the results just by cleaning the data. In blue you have the performance of the previous model, which is currently used in clinic. And in purple you have the new model, which has been trained with different classifier. But you see that by just cleaning the data, we are able to increase significantly the performance of the model. So what does cleaning the data mean? It means looking at the quality of each sample. So when you have 25,000 of samples, it takes time. Discussing with the pathologists, getting all the annotation. When you have cases which are not clear about the type of cancer, remove it. So it's a lot of time and a lot of manpower to do that. Then, so here we are trying to improve the classification itself using additional deep learning model. I will not enter into the details. So you see that we are able to increase a bit the performances, which is fine. But I mean, compared to just cleaning the data, I mean, the most important are really the data and not really the model we are using. So here you have the overall results. I mean, that's all the type of tumors the classifier is trained on. And this is a test set which has been used. You see that it works very well for almost all type of cancer. The performance starts to decrease. Here you have the number of cases we have in the training set for some tumor type. So for you cannot see here, but I mean, for instance, for breast cancer, we have a lot of patients, and the classifier is extremely good for that. For sarcoma, which is a very rare type of cancer, we have much less cases, and so the classifier starts to be less efficient for those cases. Then we try to validate the model on other data types, and this is where we start to have some issue. So you have in the literature a few, but really not that much, data set of metastasis cancer for which the primary tumors was known. So that's the perfect validation test that we can use for the model. And actually, you see that here, so it's, I mean, the performance are still interesting, but you have a lot of cases where, for instance, so where is the, you cannot see, I think, but for some sarcomas on the right, here you have many cases which are predicted as normal tissue and not as tumor tissue. And this could be explained just by the quality of the samples. You know that when you are taking a biopsy, you have a mixture of tumor cells and normal cells. And if you have too much normal cells, at the end, the classifier will not be able to find the tumor sites. So we are still working on that to try to better understand what's going on. The purity, this is what I just shown you. We have another issue with the liver, which is a very specific organ. Basically, the liver is completely different from all the other organs, and each time you have a metastasis in the liver site, most of the classifier will tell you that this is just a liver signature, and so we are not able to find the primary tumor. No? Okay, yeah, so just to conclude, because I think, yeah, it's time to stop. So this is the first time we are using such AI tool in a practical routine, and we are trying to develop additional tools that can be used for other tumor boards. We are still trying to include the additional step in the model to make it more efficient. Having a better control of the training set is the main issue. So how to collect the data, to process them in the same way, to clean the data, it's something which is very difficult. We have to face also a lot of issues which were related to the previous talk with the RGPD. So how to use all the data which are generated in the other cancer centers to improve the model, that's something which is very complicated so far. Then we can still do better in terms of modeling. And we are also working to deliver the results to the clinicians. So when a doctor just discusses a patient, it has like 2 minutes per patient, so the decision has to be very clear and very easy to do for them. And in terms of long-term perspective, we would like to start project where I told you that we have the DNA, we have the RNA, we have the pathology, we have the clinical data. So we will try to build multimodal models using all this information to give just one prediction and not multiple predictions. Okay, so quickly, I would like to thank Sarah Watson, who is heading this project at INSTITUT CURIE, data scientists which are working on that. And I would like also to thank the Rock for Life Association, which is the first patient association for CUP, which has been set up a few months ago. And actually, that's our main source of funding today. That's a really nice association. If you are living in the north of France, they are organizing some show, I think before Christmas. So, yeah, I would like to thank the patient for that. Thank you very much.